Thank you so much, Matt. We'll just get started. And as people join, they'll join. For those who don't manage to join us, we'll have the recording shared with everyone. So today we are joined by Dr. Merrill Chaya. Dr. Chaya is the director of the Children Health Data Lab at Children's National Hospital, and she's also the co-lead for Community Engagement in Research and Clinical Translation Science Institute. Dr. Chaya is a trained epidemiologist, and she got her Doctor of Philosophy of Public Health at the George Washington University School of Medicine and Health Science. So just one fun fact is I got to work with Dr. Chaya in summer of last year. Oh my God, time has gone by so quickly. We worked on a communication platform or communication tools, which was a very, very exciting project. And the aim or the goal of the project was just to identify ways to communicate childhood health opportunity index to different kinds of audiences, clinicians and also the public, which was very exciting and kind of opened my eyes to like the different health disparities that we kind of see in the different landscapes that we have in US. And I'm really, really honored to be in this session with Dr. Chaya. So I'll just hand it over to her, to you, Dr. Chaya. So please take it away.
Great. Well, thank you so much, Dolly. It's, again, very nice to see you. We had a great working relationship for a few months. So let me go ahead and share my screen with everyone. I do have a slide deck that I will talk through. But, at any point, if you want to interrupt me because you have some questions or some thoughts to share, always open to that as well. So hopefully everyone can see my slides. Dolly, can you just nod if you can see?
Yes, yes, I
can see you on my screen. Okay, great. Yeah. So I'm going to go ahead and minimize everyone's faces. I won't know if you're making funny faces, if you're not understanding. So you're going to have to speak up if you have any questions or need any clarification. Okay. Start at the beginning. Okay, 1 second. Okay, here we go. All right, so the talk today that I'm going to give is about how neighborhoods matter, and we're going to be specifically looking at place and race-based inequities and child opportunity, and very, very specifically on the DC area, which I know is close to Hopkins. So this hopefully is interesting to folks that are here, and you'll start seeing some or learning some information about the area in which you're going to school, or at least close by, that you might not have known before. So again, my name is Chaya Merrill. Dolly gave a nice introduction. A tiny bit more about myself. I work for Children's National Hospital in Washington, D.C. Been there for now approaching 12 years, so 10 plus years. I'm the director of a department called the Child Health Data Lab, and the Child Health Data Lab is within our Advocacy Center. I also work in the community engagement space, specifically with our clinical and research translational team. I'm trained as an epidemiologist and public health data analyst. Did some work at Hopkins over the years, received my doctorate in public health in 2010 at George Washington University. But maybe what's most important to this group is that I'm just very deeply personally and professionally committed to the concept of health equity, and very specifically for children, and how do we use data to achieve health equity. I wanted to say a couple words about the Child Health Advocacy Institute, which is the institute that I report up to at the hospital, because if any of you are interested in working for a hospital at some point, it's good to know that there are some hospitals that incorporate advocacy into their mission. It is still pretty rare. Our hospital, Children's National, has a 4-part mission: care, advocacy, research, and education. So it's right in there with, alongside of clinical care and research. We elevate advocacy, which is essentially, advocating for better health and health equity for all children. This is the mission statement of the advocacy. It is through leadership and collaboration, we are looking to advance health equity by advancing policy and systems change. In this talk, I'm going to cover the concept of health equity, talk a little bit about health inequities in DC specifically. And these health inequities in DC are really not that different than what's going on in Baltimore, where Hopkins is located. I am from Baltimore, so while I'm not at Hopkins anymore, I've spent a good amount of time at Hopkins in various ways. I mean, I used to live right outside of Baltimore City, so I know the area pretty well. I'm going to talk a little bit about our hospital's upcoming community health needs assessment and the framework that we're using that's called the Child Opportunity Index. And I hope you find this interesting. I know not all of you maybe are in the healthcare space or used to working on this, but I do think this has a broad reach conceptually to lots of different audiences. What do we mean when we say health equity? It is a buzz term, especially if you're in the healthcare field, if you're in the public health field. It's one of those terms that people throw around all the time. This is a graphic that's often used to describe what we mean by equity. And you see that there are different people of different heights. There's one tree that has fruit. We can't give everybody the same size stool and assume that they're going to be able to reach the fruit. So the shorter little girl on the end, left-hand side end, needs a slightly bigger stool to be able to reach the fruit. The really tall guy on the left, he probably doesn't need a stool that's as big to reach the fruit. And I always laugh because obviously most of you have not met me, maybe except Dolly, but I'm that shorter little girl right there. If you gave me, a really short stool, I never would have been able to reach that apple. So really it's about the concept of giving people what they need to succeed in life and not giving everybody the same exact thing. That would be equality. This what we're talking about today is equity. Another really good definition that helped me kind of really understand the concepts of health inequity is this one from the American Academy of Medical Colleges. Health inequities are measurable, they're systemic, really importantly, they're avoidable, and they're unjust differences in health. And many times these differences stem from differences in social advantage and disadvantage that come from our childhood. I think the red words here are really key. And for me, what's really key is that they are avoidable. These are not differences that have to occur, that with the right policy interventions, systems interventions, we should be able to avoid these. A quick look at some of the health inequities in DC, some of the more striking ones. So this right here is a map of DC. Maybe some of you are familiar with DC, but if you're not, you'll be seeing this map over and over again. So remember this shape that you're seeing. Generally, what we see is that the western part of DC, where the life expectancy is almost 90 years, has a lot of resources. And kids that grow up in that area, Woodley Park is the area that arrow is pointing to, but really anything, on the western and the northwest DC, lots of resources, people do very well, income levels are high. And then you look at more of the eastern side of DC, northeast and southeast, where that Anacostia region is, and lots of challenges there, not as many resources invested in that area. So you can see from looking at this map what one of the very basic discrepancies are that children born in Woodley Park can expect to live 21 years longer than their peers born in that Anacostia area, specifically in St. Elizabeth, which is a part of Anacostia. That is a pretty striking difference, almost 90 years to about 68 years of life. This is also a map of DC, again, if you remember that shape. And what this is showing is income patterns. So the blue dots represent areas where the household income is over $200,000 per year, per capita income rate. If you look, I'm sorry, it's not per capita, it's the house. If you look at the yellow dots, that shows the lowest income areas, and that's where households earn less than $25,000 per year. We're talking $200,000 household income versus $25,000. And what you see is that there's a stark difference. It's almost like a line right in the middle of DC where the blue is on one side and the yellow is on the other side. So geographically, these disparities are really striking. What I'll also tell you is that the blue areas of the city are where most of our white children live, and the yellow areas of the city are where most of our Black children live. And this again is a pattern that you'll start seeing over and over again in DC. So one more just quick tidbit about the health inequities that I think is quite striking is if we look at it very specifically by race, if we look at median household income in 2021, For our Black families, the median household income was under $50,000, whereas for our white families, we're approaching $150,000. This is a look at inequities by race. And hopefully this is really striking to you. I don't think that most people that work in this space probably understand that there are racial inequities, but I think sometimes seeing these numbers and seeing it mapped visually really has a profound impact. Inequities by place and race are quite profound, and they're related. As you can see, the concept of race and place are not two distinct measures. Certain types of people, certain races live in certain places, so there's an interplay between. What I always say is, a child who looks like this, or a child who looks like this, or like this, should not inherently it looks like my audio went out. Hopefully everyone can hear you. Okay. Oh, you can hear me again? Yeah. Oh, okay. Yes. I got some kind of note that the audio went out. Okay. Sorry about that. So yeah, these children who look differently should not be born expecting a different trajectory. And children should all have an opportunity to succeed and, achieve their potential. That's going to get me into the work that we're doing with our community health needs assessment. So now I'm going to transition a little bit into one of the requirements our hospital has. And I'm guessing most of you are not familiar with this, but all nonprofit hospitals, and most hospitals in the US are nonprofit hospitals, are required to conduct what's called a community health needs assessment every 3 years. What that basically means is that we need to take an assessment of the communities that are around us and decide what are the priority areas in that community that are driving health inequities. And as a hospital, we're required to focus on those areas. So this is something we've got to do every 3 years. It's required by the IRS. The IRS, however, doesn't really give us a lot of guidance. It's not very prescriptive. Hospitals do all kinds of things to meet this requirement. What we did for our community health needs assessment this year for this round, which is due in June of 2022, is look at differences in opportunity for children that live in our primary service area. So that's what I'm going to be talking with you about. So in addition to conducting this assessment every 3 years, we also have to develop a plan that says, how are you as a hospital going to address the needs that are identified in this assessment? And then we need to make all that information really widely available. So here's a quote that I like. Children are not the people of tomorrow, but they're people today. They should be allowed to grow into whoever they were meant to be. The unknown person inside each of them is the hope for the future. I think this is a good quote to set up the idea and the framework for how we conducted our community health needs. We used a framework called the Child Opportunity Framework. What do I mean by child opportunity? What we're talking about are all the neighborhood features, whether it's things like the quality of the schools, the parks and playgrounds around a community, access to healthy food, to healthcare, to safe housing, all these features that allow a child to grow up in a healthy way. We focused our 2022 pediatric needs assessment on this. And to do that, we used a tool, and the tool is called the Child Opportunity Index. So what this tool does, and this is a tool that was developed with funding from the Kellogg Foundation and the Robert Wood Johnson Foundation. You may have heard of these names, really big philanthropic organizations, very reputable organizations. So this tool was developed with funding from those organizations. And essentially what it does is it looks at 29 neighborhood level indicators. I'm going to show you what those indicators are, but there's 29 of them. And it rates every single neighborhood in the United States. And I'm using the terms neighborhood and census tracts a little bit interchangeably, but there are about 70-some thousand neighborhoods or census tracts in the United States. And it ranks every single one of them on the level of child opportunity within that neighborhood based on these 29 indicators. So there's like a whole complicated research methodology behind this, which we don't have time to talk about today, but if you're interested, I'm very happy to point you towards some resources to learn more. But each neighborhood is ranked on a scale of 1 to 100. So neighborhoods that are ranked closer to 100 have really high levels of opportunity. This is where, children have an opportunity to thrive. They are being set up for success. Neighborhoods that are ranked a 1, the lighter blue, almost white areas on this map, those are neighborhoods that have a really low opportunity to thrive. This is where children are going to face a lot of obstacles. So they're going to have to work extra hard. It's an unfair disadvantage for them. Let me actually go back real quickly. So what you're looking at right here on this map to the left, again, this is a map of DC. You should start seeing that same outline. That should be familiar right now. Remember again that the darker areas are areas of high opportunity. You'll start seeing and hopefully noticing that pattern that I showed you earlier, a couple of maps, that the health inequities in DC do tend to be concentrated in one part of DC. You see that the darker areas of DC and even beyond DC into Maryland that are really dark are concentrated in one part of our city. And then again, you look at the eastern part of DC, northeast and southeast, and really light areas closer to that score of 1, which means that these neighborhoods have not scored very high on child opportunity. These are the short names for the 29 indicators that are included as part of the index. Give you a minute just to take a look at that. They're divided into 3 domains: education, health and environment, and social and economic. So again, I think it makes a lot of sense to people, access to healthy food, having access to healthy space, green space for kids to exercise and walk outside, clean air, safe housing. Education is a huge one. What is the high school graduation rate in that neighborhood? Poverty, obviously, a big one. So things like that. So these are the 29 indicators that get rolled up to that composite indicator. And then these neighborhoods all get scored across these 29 indicators. All of these indicators, the 29 indicators, are weighted differently based on their importance in predicting a child's opportunity to grow up. Again, there's a whole research methodology behind this. Maybe some of you are thinking, well, what does opportunity actually mean? What's the outcome variables that you're looking at? The general outcome variables are physical and mental health. So the self-reported physical and mental health as an adult based on, and they track this back to the neighborhoods that these adults have come from, as well as economic mobility. So it's financial as well as physical and mental health. So all kinds of regression models are run to look at these 29 indicators to say, how much does this indicator contribute to an individual's opportunity to thrive, meaning their ability to live a healthy physical and mental health life, as well as have economic mobility. So I just want to show you this because if you have an interest in learning more about the Child Opportunity Index, there is a website you can go to. It's in the top left-hand corner of the slide. You'll have access to these slides, diversitydatakids.org, where you can actually put in your home zip code. I mean, if you're all students at Hopkins, I'm assuming you're not all from the Baltimore area. You've probably come from many different places across the US and even beyond. This tool is limited to the US, but if you're from California, if you're from Tennessee, Michigan, wherever you're from, you can actually put in your zip code or your city and state and look at opportunity levels from where you came from. So it's actually quite fascinating to pinpoint your home neighborhood, say, oh, well, that's interesting. My home neighborhood is considered a very high opportunity neighborhood. Hence, I've had this wonderful opportunities to end up at this wonderful university. Or you might look at it and say, wow, like I didn't realize that I'm at a moderate opportunity neighborhood or even a low opportunity neighborhood. And hopefully it'll be a little bit enlightening, but I think it's very interesting for people to understand like where they came from and the opportunity levels within those neighborhoods. And you can actually dig quite deep on this online tool where you can actually start looking at, well, which of those 29 indicators was my neighborhood scored really high on or really low on? Might be kind of enlightening. So I just wanted to show you that this is the website that you can go to take a look at that. So in terms of Children's National Hospital, and it says NHSC, which is our partner pediatric center, but really I'm talking broadly from Children's National Hospital. This is the primary service area that we work within. So right here in the middle, unfortunately, oh goodness, my slides just went. Oh, sorry about that. Hold on, let me just. We all know that Zoom sometimes has a mind of its own. My pointer is not working, unfortunately. Sorry about that, but you can see that the District of Columbia is right in the middle. It's that shape that you've seen now a couple times, and then parts of Maryland are in red. So that entire area in the red, which is Montgomery County, Maryland, as well as Prince George's County, Maryland, and obviously DC, are our hospital's primary service area. So we focused this needs assessment work on our primary service area. The hospital serves patients across the country, but you'll see also parts of Virginia are considered our secondary primary service area, as well as other parts of Maryland are considered our secondary service area. But our primary is Prince George's County, Montgomery County, as well as Washington. So we took a look at that Child Opportunity Index, and we basically remapped everything to look only within our primary service area. We wanted to norm the data to our primary service area. Those initial maps I showed you were normed to the nation. So how does DC compare to the nation? Right now, we're comparing just within our primary service. So again, you see the outline of DC in the middle. And now this map also contains parts of Maryland. And again, what you start seeing is even when we reran the numbers and recalculated all of our metrics and normed to this area, the same areas of DC are in that lighter color, which is very low opportunity, compared to the really dark areas of DC and Maryland, which are the really high opportunity areas. So again, this is just showing you where the inequities are and how stark it is, how concentrated areas of inequity are in our city, in our primary service area. So for the needs assessment, we basically took a look at the lowest scoring neighborhoods in our primary service. These are the neighborhoods in DC that are DC and Prince George's County that are noted on this slide in red. You see that they're all concentrated if you're looking at DC on the eastern part of DC, and then there are some areas in Prince George's County, Maryland, that also are in the bottom 10th percentile of opportunity scores. So for us to select a neighborhood, it had to be in the bottom 10th percentile, as well as have at least 1,000 children living in that neighborhood. Because there may be some neighborhoods that are very low opportunity neighborhoods, but don't necessarily have a lot of kids living in them. We wanted to really pinpoint those neighborhoods that are really low opportunity and have a lot of children living in them. So for our needs assessment, from our hospital's perspective, we want to work really specifically within these neighborhoods. Once we identified those neighborhoods, and there was a little bit more analysis, it's maybe a little too detailed for this presentation, that we looked at those neighborhoods and then we looked at really specifically which of those 29 indicators each of those neighborhoods was scoring poorly on. We did a ton of community engagement work where we went into these neighborhoods and we conducted a number of community engagement activities. These are the names of the neighborhoods. There happen to be some DC folks on the call. For community engagement activities, we went into these neighborhoods and we had community conversations, which are also known as focus groups, with other residents who live there. And really, we wanted to present the data that we were seeing and then talk with residents who live in those neighborhoods to get their perspective. Do they agree with the data? Do they have ideas for what hospitals like Children's Nationals can do to help address these issues? We talked with government leaders, community leaders. We issued a community input form, which is essentially a community survey within the community, but also at our hospital. And then also had what's called a photo voice project. And this was a pilot project. So we only had 11 students, but we wanted to see if students would be interested in engaging in this process where we asked them questions to document their perspective on opportunity in their neighborhood through photography. So that was an interesting project where they would use a camera to show us what they thought about opportunity levels within their neighborhoods, but very visually. So part of the needs assessment process, after running all that data, and this entire process probably took almost 18 months to complete. I'm boiling it down, but it was a very tedious, long process. We wanted to get it right. At the end of the needs assessment process, the hospital needs to say, okay, now we've picked the neighborhoods, exactly what are our priority areas. Of those 29 indicators, which are the handful that we want to focus on for the next X number of years? And the way this works is the hospital then commits to focusing on whatever the priorities are for 3 years. So the hospital then is required to invest in in the areas that are picked. And you saw the indicators that I showed you, they're all important and they're all, dependent on each other. So how do you pick between things like, college access or food access or, the availability of healthy food? I mean, they're all really important indicators. So I like to say that we wouldn't have gone wrong had we picked any one of the 29, but we did want to use a structured method to prioritize these indicators and try to minimize the personal bias. The method we use is called the Hanlin Method. Won't go into a ton of details about this, but the way this works, because it may be useful to you in the future if you've got a lot of different issues and you need to prioritize them. Essentially what you do is you look at all of the indicators, so all 29 indicators, and then we rate each of the indicators according to the criteria that are listed on the screen. So for each of the 29 indicators, how much of a community priority was it? So when we talked with the community, did our community feel like this was a really high priority or low priority? Within the hospital, we talked a lot with our hospital leadership and staff. How did the hospital, our clinicians feel in terms of, was it a hospital priority? Did our hospital even have the capacity to address this issue? Did these indicators align with the hospital's mission and vision? And was there existing work related to these areas? It's probably easier to understand if I show you what this actually looked like. I just showed it to you in this slide for just like 10 of the 29, but imagine that there were all 29 indicators. And we assigned a score from 1 to 10 for each of the 29 indicators. So each of the 29 indicators across those criteria. So let's take a look at something like access to healthy food, which is 7 on this list. Our community really felt like that was an important issue. Some of you may know, and probably the same issue in Baltimore as it is in DC, lots of food deserts. People that live in parts of DC do not have easy and equitable access to healthy food. So our community members, when we met with them, thought that this was a huge issue. I mean, this really impacts a child's opportunity to thrive, because if you're not well nourished, how are you expected to do well in school, to have access opportunities? So they rated that really high. So we gave that a 10. Our hospital, our clinicians, our staff felt the same way. Felt like, you know what, children need access to healthy food. There's no way that they're going to thrive and develop in a healthy way if they don't have access to healthy food. So if you kind of look across, the access to healthy food almost got 10s all the way across. The only area that it scored a 9, which is also very high, 10 being the highest score, was in existing collaborations and interventions. There wasn't as much work being done in access to healthy food at the hospital level compared to something like health insurance coverage, which is indicator number 6 that's on here that got a 10 for existing collaborations. Then there's some math that's done, and there's a final score out of 1 to 10, a weighted score for each of the indicators. And those indicators that scored the highest are the indicators that we as a hospital have decided to elevate as part of this community health needs assessment process. These are the 4 indicators that scored the highest and that our hospital will be focused on for the next 3 years. Early childhood education, access to healthy food, employment in communities, so increasing the employment rates, and health insurance. These are the 4 indicators within those neighborhoods I showed you earlier that the hospital will be investing in. So my final thoughts about the Child Opportunity Index is we think it's a really structured way to start a conversation about health inequities that are present in the area. We think it's a really powerful tool visually that makes an impact on people. So I hope that you found this interesting and one way to look at health inequities for children. And again, what's really nice about this tool, there's so many nice things, but one nice thing is it can really be used for any community. So while I showed you how we applied this to the hospital's primary service area, which is essentially Washington, D.C., as well as a couple parts of Maryland, if you are interested in this type of work, really this can be applied to any community in the United States because the data are publicly available for every single census tract in the United States. I do want to just thank the Kellogg Foundation, the Robert Wood Johnson Foundation for funding this work, for researchers at Brandeis University and Ohio State University that really were critical in coming up with the methodology behind this work. The Children's Hospital Association for support. If you're interested in learning more about the Opportunity Index, here are two really good articles. One fairly recent, just January 2020, in Health Affairs, which is a really reputable health services research journal that you can take a look at, that explains the process of the Child Opportunity Index and how it's applied. The 2014 article is interesting because that is based on the first version of the Child Opportunity Index, version 1. And between 2014 and 2020, there's another version that's been released, and that's the version 2.0. So the second article talks a little bit about the evolution from the first index to the second index and lessons learned. And now the researchers are working on version 3.0. So this is a tool that will continue to evolve. I leave you with one quote that I think summarizes this work well. And it's that when a flower doesn't bloom, you fix the environment in which it grows, not the flower. That would make a lot of sense to people, right? I mean, if you have a flower that's not blooming, a plant that's not blooming, it's not that you're blaming the flower. You probably think, well, it's the soil, it's the environment that the flower is in. Well, we tend to look at children the same way. We're not looking to fix necessarily that individual child, but the environment in which that child is growing. And I think with that, I will stop sharing my slides and thank you for your attention and open it up to any questions that you may.
Thank you so much, Dr. Chaya. So anyone with questions, feel free to unmute yourself or post it in the chat box and then we will read it out. And maybe we can just start this off as well, Dr. Chaya. Like, I feel this is a very relevant topic, especially in any industry or in any market. Do you think this can be done in low and middle income countries? And I'm speaking because I come from that space. Is this something that can be replicated outside the US? And what is needed to build it up to just make sure it's successful in other spaces?
Yeah, that's an excellent question. Conceptually, yes, this can be replicated. But there would be practical considerations. One of the reasons that those 29 indicators were selected is because there are data available down to the census tract level for those specific indicators across the United States. So if anyone remembers the list of the 29 indicators, one of the questions we get, and Dolly knows this from our prior work together, is why is something like community violence not included? I mean, especially in an urban area like Baltimore, like Washington, D.C., we all know that community violence is a really critical indicator when it comes to child development. Children that are growing up living in areas with a lot of violence are not going to have the same opportunity levels as children that are growing up in safer areas. So why would that not be included in the index? And the answer for that is the community violence data were not available down to that census tract level across every community in the US. So I can see that being a challenge, Dolly, in implementing this. So conceptually, yes. I mean, for statisticians, this probably isn't a brand new concept. A composite indicator is not something that's like revolutionary. I mean, in some fields, it might feel like, wow, this is really interesting. But if anyone on this call who is used to working with regression models, I mean, we're all often looking at multiple indicators and the amount of variance that indicator explains relative to whatever outcome you're studying. Our outcome, again, is child opportunity, and we have this big regression model of 29 indicators, but you can only include the indicator if data are available, right? So I think that would be the challenge. So you might end up with a biased perspective because there may be indicators that are really relevant in these areas, but unfortunately the data are not available to support it.
Okay, thank you. I think we have another question in the chat. I'll just read it out. Did the team face any barriers in trying to get engaged with the community to know how they feel about their neighborhood, and what barriers did you face?
Yeah, that's an excellent question. From a community engagement angle, it is critical to involve communities in the entire process, ideally from idea generation to implementation and dissemination. And I'll tell you, I'm one of those people that crosses both of those spaces. I do work at an advocacy institute that does a lot of community engagement work, but I'm trained more in research, and it's a lot harder to do than it might seem. So the barriers, I would say, is that often hospitals like ours, Hopkins academic institutions, George Washington University, are often viewed by the community with some distrust for many, many reasons, many, many historical reasons. So when you go into communities, you almost have to, it takes a very long relationship building process to be able to have conversations that are really meaningful. They often see the researchers that are coming in as, ivory tower. You've already set up your research. We're just your subjects. You don't really care about the community. So there's often that barrier that's faced. And really the only honest way to address that behavior is to start building long-term relationships from the very beginning, right? You can't expect to go into a community once you've already done your quantitative research and now we want to present this to you. And it's almost like talking at people versus collaboratively working with people. So that's always a challenge. And while it might make sense to say this, I'll say most people don't do this. When you're thinking about research, you really should be meeting with community members before you even get like that first research statement down. Present ideas, have a conversation. Because if you go to communities after it's already well thought out, there are a couple of things that happen. One is you've often missed the mark. Like you're studying what's important to you as a researcher and not necessarily what's important to community members. And second, let's say you've even have landed on something that's important to community members. Without community buy-in in the process, you can do all the research you want, but if people don't believe in your work and are not going to support it, especially at like a community leader level, you're not going to impact change. So that's a little bit of the difference between research and advocacy, where I think it's fascinating. People are generally trained in one or the other, right? So like my training was in research. We never really talked about what happened with the results when they were done. And then, I graduated with my research degree and started working for an advocacy institute where they're much more about like the action on the ground. So people that are, I think, well-versed in research and in action understand the importance of engaging communities from the very, very beginning and the challenges that are inherent in that.
Okay, thank you. So one more question. Thank you, Fan. One more question is, one of the biggest conversations that now happens in the healthcare sector, especially from a health equity standpoint, is cross-sectoral collaboration or working with different sectors, because health is not only like a healthcare problem. It could be, if we want to fix transport and access to food for the food deserts, we need to bring different stakeholders to the table. So how has that experience been? Like, what are the success factors? What has worked from, for Children's National Hospital, and maybe what are the pain points that you've experienced in trying to bring all the different and relevant stakeholders to the table?
Yeah, absolutely. We are never going to impact change if we don't work together. And I think, old school thinking that, health should only work in health and transportation. And, people would say things like, you need to stay in your lane. Like, so for a hospital, that wanted to work, let's say in housing or food security, and we still face that challenge. I mean, maybe the folks on this phone call and the work in academics might see it differently, but that average person who's working, whether it's in a hospital or working in the housing industry or working in the food industry, generally sees like, my lane is this. I work in clinical medicine, so I should be worried about things like asthma and diabetes and clinical conditions, and really don't tend to give a lot of thought as to maybe, well, why do we have an increase in type 2 diabetes, or why are asthma rates exacerbated in this community? And often they're not clinical reasons, right? I mean, there's a lot of research from the clinical side to show that only about 20% of a person's health outcome is determined by clinical care. 80% is decided by things outside of healthcare. And a good number of that is environmental conditions, a good percentage of that, but it's also behaviors, and behaviors are influenced by your environment, right? So if you, for example, I always think about it from a food insecurity or obesity perspective, that people that don't have access to healthy food, that's their environment, but that leads to unhealthy choices, which then leads to diabetes, which becomes a clinical issue. So rather than only focusing on the diabetes at the end, why are we not working on making sure that our communities have access to healthy food? Why are there food deserts? Why shouldn't everyone have equitable access to healthy food? I mean, it's ridiculous to, in some of our families, I mean, you can see it on a map, but until you start talking with the families, the things they have to go through to get to a grocery store, it's actually really heartbreaking that so many children and families live in these conditions where, I'm very fortunate. I'm sitting in my office space right now, and within probably a 2-minute walk, I've got 3 full service grocery stores. I have a Whole Foods, I have a Trader Joe's, and a Giant. I don't need 3. I only need 1. And these children don't even have 1 in certain communities. So, that was a long way to answer that question, that yes, absolutely important to work across sectors. If you remember some version of the 29 indicators I showed, they do cross sectors. There's, the housing sector is represented, transportation is represented. The hospital does have longstanding relationships across these sectors that we draw upon. But I'll tell you, it's still difficult. It's still difficult because when we all come to the table, if I want to work on a housing initiative, because one of the examples at the hospital right now is we have a really high percentage of children who have asthma. And asthma is often triggered by housing conditions. So we're trying to work with our housing partners to make sure that the housing is safe for children who live in this community. There aren't triggers like, pests that live in the house, or dust, a lot of high dust and pollution, all these things that trigger asthma. It's not always received very favorably that healthcare providers come in and try to talk to housing people about this. So I would say the answer is similar to working with community. It's all about relationship building and trust, knowing how to stay enough in your lane, but also reach out as well, respecting other people's expertise, because the opposite of that, Dolly, is like, I would never think that a hospital should go in and be prescriptive about things like housing or food insecurity, because that's not my area of specialty. I might know the right questions to ask, just like I would never want somebody from transportation to come to my hospital and say, this is how healthcare delivery should happen. Be like, well, you don't really work in that space, but I'm happy to listen and have that conversation. So it is incredibly important to involve people from other sectors. There will never be any progress at that prevention level otherwise.
Okay, thank you.
And let me give you, if you don't mind, just one really quick example on the intersectional kind of benefit of working across groups, something just recently that happened at our hospitals. So thinking about something like food insecurity, a lot of our children don't have access to healthy food, which like I said, leads to other clinical conditions. We partnered with the Capital Area Food Bank, which is a food bank in Washington, D.C., to open up a food pharmacy, is what we're calling it, within the hospital. So this is just an example of the food sector working with the healthcare sector that we partnered with them. So we have a section of the hospital right now that's actually in our diabetes clinic, interestingly, and that works out well because obviously diabetes is impacted by food choices, where when children and families come to the hospital and they're identified as being food insecure, not having great access to food, while they're at the hospital for their appointment, they're able to walk over to the food pharmacy that we have that has fresh fruit and produce to take a week's worth of produce home with them. So that's just an example. Is that going to solve everything? No, but it is one example of steps towards 2 sectors working together to make sure kids have access to healthy foods.
Okay, thank you.
Great work. Like I'm so surprised by the map and the accuracy of like each neighborhood. I was playing with that website you showed and was like so surprised to see all this data. Just a general question, like what's the next step? Like in your like 3.0, are you planning to include more data points, or are you trying to reach more like geographic locations? What's next?
Yeah, that's a great question. So the good news is the index has received additional funding from the Kellogg Foundation to do exactly that, to develop 3.0. And there are a couple of things that it was just received. So it's brand new, so it's all being worked out, but there are a couple of things that I know are going to happen. One is the tool will be released annually. Right now, there is a several year gap. So the data that you're looking at the tool is not necessarily timely right now. Sometimes that's okay because these neighborhood conditions don't really change, unfortunately, very quickly. So even if you're looking at data that's a few years old, it's generally still fairly accurate. But of course, we want to use as timely data as possible, especially in urban areas where there's a lot of gentrification and things are changing quickly. You want to be able to show, like, for example, a couple new grocery stores are being built in areas of DC that just didn't have access to a grocery store, but the data don't reflect that because the data are from 3 to 5 years ago. So I would hate to make an assumption based on that data when I know personally, just living here, that there's a new grocery store. Why isn't that reflected? So that is one thing, that the tool will be more timely and updated every year. So you'll be able to track how things are changing at a yearly level, which I think is all you need. You don't need to go anymore. Like sometimes people want to get, every 3 months, 6 months. I think a year is fine. So that's one big advancement. The other is definitely looking at other indicators. So community violence being one of them. There are some indicators that I think are super important to certain types of communities. So working and living in an urban community, I think it is a huge limitation of this tool. That things like community violence are not included. I think it's showing a false image. Most urban communities, including Baltimore as well as DC, have really detailed crime data. I mean, we in DC and in Baltimore have sadly very detailed crime data, probably because the crime rates sometimes are a little bit shocking. So people are tracking those. So we're pushing for developing versions of this tool that are appropriate more for rural areas versus urban areas. And for the urban ones, we'd be able to include those types of indicators. So just getting a little bit more nuanced, trying not to have a one size fits all type of tool, because right now that's what it is. This is a national tool that it has its benefits because you can look across the country. Like you said, you were able to go in and kind of look at your own neighborhood. That's appealing. But when you're really broad like that, you're sacrificing some of the accuracy. So that is something that version 3.0 will focus on.
Thank you. Great to know about that.
Mm-hmm.
And as you mentioned, I think this map really correlates with the crime map I was looking at before, like especially for the Baltimore area. I can see like those colors really match to the crime. Yeah.
And that's sadly, and I'm not an expert on rural health, so I don't know much about, I know a little bit, but I don't know if the same holds true for rural areas. But I will tell you from all of the urban areas I've looked at, and again, I grew up in Baltimore, so I'm familiar with Baltimore, absolutely holds true for Baltimore. I've worked in DC most of my adult life, so absolutely holds true for DC. And I've also done some work in Philadelphia and Chicago, and it's really the same story in all of these urban areas. Like I say that map, if I don't have a legend next to it, I could use for almost any kind of burden, and it would hold true. Like if I was to say to you, areas of the city where asthma rates are the highest, areas of the city where it's hard to access food, that map would look exactly the same, where the health burdens are all concentrated in the same areas and the resources are concentrated in another area.
Hey, Dr. Merrill, this is really interesting work and very important stuff that you're doing. I've seen maps of the similar things in Baltimore, and it's definitely a very disparate thing that's going on, and a lot of factors play into it. And I'm curious from an implementation and change standpoint of things. You mentioned an ivory tower mentality and how it can be difficult to convince communities that you're on their side, and that can also inhibit the ability to actually enact some of this change. Like using the food as an example, building a grocery store might not guarantee that people will actually use it or accept it, or maybe they don't have time, maybe they don't have money or resources to do it. And I'm curious, either your hospital or other community members that you're aware of, what strategies have you seen that actually help accelerate the adoption rate for interventions that happen and actually help these people see that the change is important and will actually help them in the long run?
So let me give you a broad answer and then something really specific. And the broad answer is probably the obvious expected answer is a lot of this is about relationship building with people. And I talked a little bit about that. But let me give you a really specific example of something that's been successful in this area is partnering with community organizations that already have trust in that area. And the example that works in wards 7 and 8 in DC, which is that eastern part of DC that we talked about, is the religious community, so Black churches specifically. So we have been pretty successful in different initiatives by connecting with the pastors, priests, leadership, clergy of those churches, and working with them to disseminate some of the findings. That absolutely worked with COVID, for example, when we came to vaccination rates. I'm sure you all have heard that the uptake of vaccines in some of our communities, and specifically in our Black and Latina communities, was not nearly as high as it was in white communities. And there's lots of speculations as to why, or speculation as to why. And some of it just comes, again, from that historical distrust of healthcare. And it's hard to blame, underrepresented minorities or people of color as to why they have distrust. We haven't necessarily treated communities with a lot of respect historically, and that distrust has just come down generation to generation. So what we started noticing in DC is the uptake of the vaccine was really low in wards 7 and 8. Again, predominantly Black communities where there's a lot of health disparities. And that's devastating because especially, Omicron is one issue, but when we had variants that were much more lethal, we were seeing rates of infection that were much greater in our Black community. So we did partner with some of the churches in the area and work with the pastors. And first we had to sell the message to the pastors and the clergy, but that wasn't as hard. One-on-one with individuals who sometimes have a certain education level, are leaders in their community, we were able to do that pretty convincingly. But the part that was really critical was having them message it to their congregations and to the people that believe in them. And that really did spike the vaccination rates. It was very easy to see, like, oh, we worked with X and Y churches. It draws from people in these communities. Wow, look at those rates. We were following the data. Like the next day, there'd be spikes of people that are going to get vaccinated because they were told that it was important from somebody that they trusted. Versus had I just gone in and said, and tried to give you the science behind it and the reasons behind it, probably would not have had the same uptake. So maybe the example there is that, first of all, never underestimate the power of the religious community. That is something we've learned, especially Black churches, but it doesn't have to just be religious. Any trusted community organization that already has the trust and support of communities, that's who you want to partner with. And to do it in a genuine way. In healthcare, it's always genuine. We're really looking to how do we promote healthy behaviors that ultimately are going to, benefit the community. It's not about benefiting us as a hospital. And in fact, it's a challenge sometimes at the hospital because the more we promote healthy behaviors, it's almost like the less kids that are coming into the hospital. Like we do a lot of work to reduce asthma rates in our community. And the more successful we are there, we see less kids with asthma coming into our ED. And that's how we make our revenue, right? So there's an interesting dynamic there as well. We're trying to keep kids out of the emergency department, but you know what? Those ED visits bring in a lot of revenue for the hospital. So at the end of the day, we want what's best for the children. It's not just about a money-making grab for the hospital, even though we are a business, and those are all things we need to consider. So I hope that answered your question, Matt.
Yeah, no, absolutely. It points to, I think, a larger issue too. Obviously, I think this is a good first step to kind of bridging the gap, because the other striking part of the map that you shared is the divide between white and Black communities, and I think this is an important first step in helping us get some kind of cohesion through society, so that maybe the next time we try and help everybody out, we don't have to be very specific about who we interact with. We establish those relationships and that trust gets built. I think that's really powerful.
Right. And, and another small thing I'll add is that we've learned that it's important that when we go into communities, we go in with people who look like the community, right? And that's like what you're saying, Matt. Hopefully over time, maybe that won't be as important. And maybe someone could look at somebody like me, and I'm of Indian descent. Sometimes it's okay for me to go in, considered a person of color. Sometimes it's not. It's kind of figuring out, who do we bring in that will help build that trust? Who do we hire? So that's like another aspect that we haven't really talked about from a workforce perspective. We want our hospital to reflect, at least at some degree, the communities that we serve. So we serve a largely Black population at the hospital, but most of our higher level execs are all white. So there's that issue right there. So correcting all of that. So when we come into the community and we want to talk with people, do we look like the community we're serving? And if we don't, what steps are we taking to make sure that that happens over time? That's not going to change overnight. But what can we put in place at the area high schools, internships, high school opportunities to make sure that that happens over time?
Thank you so much, Dr. Chaya. I'll hand over to Matt to take over.
Yeah. Do we have any last minute questions, or have we wrapped up everything? Just want to give everybody a chance to chime in if they have any lingering thoughts. Awesome. So thank you again, Dr. Merrill, so much for coming and talking to us today. I think this is a really important issue to discuss. And you know, the impact of your work, I think, is going to continue to be obvious as time goes on. I think these are very big things that are very important for the community. And certainly these issues that we've talked about today are the kinds of things that consulting firms are being brought in to work on. So, you know, it's a great look at the type of work that I think a lot of us should be doing at some point in our careers. So thank you all for attending, and we really appreciate you know, your insights today, Dr. Merrill, and thank you all for coming.
Thank you very much for inviting me. It's been a great conversation.